I'm so excited that one of my co-authors is here, Dr. Townsel. And if she is anything like me, as I was preparing this, I was thinking, okay, it's been a while since we published this. Remind me of what we did. So last night, as I was going through this article again and some of the slides we have for different talks, it was a nice reminder of like the work that you do and put out there in the world and then have to remember the details of. Um, and so I'm Lauren Oshman, and we're going to be talking about this article today that we published in the Journal of Substance Use and Addiction Treatment. I am just going to capture the aura of Jamie Huizinga, who is the first author on our article. She's now an intern in obstetrics and gynecology at Michigan State University and has to go to clinic today, so she can't be here. But really sad that she's missing it and had planned to present with me. My name is Lauren Oshman again. I'm a professor in family medicine as of 2 days ago. Promoted, which is very exciting, at the University of Michigan, and have in my practice included family medicine obstetrics for almost 20 years. I'm going to start with some context. I think it's really helpful when we think about single site studies to understand what our community is like. And we are at Michigan Medicine. This is a view of like our hill of all of the major university hospital complexes. Um, and we're an academic health center, kind of tertiary care academic health center outside of Detroit in Southeast Michigan. We're also a Big Ten school with a big football culture, so go blue. We have a large volume of deliveries. We're at about 5,500 deliveries a year or births per year at our hospital. We have a really diverse community socioeconomically and racially, from like a very rural clinics where I work in Chelsea, Michigan, where I have to go through many cornfields to get to my office, and then closer into Detroit where we have more urban type of a city. And so we also have catchment from our health system practices, which, as you might imagine, are a more homogeneous population, as well as federally qualified community health centers, as well as a private practice that is focused just on Catholic healthcare, as well as a practice that's just focused on moms and their kiddos who are in their young 20s, right? And in our more urban area of Ypsilanti. So not only variability in our patients, but also like these very pocketed practices that meet needs for our community. So, you think of where our research questions come from and where this work came from, and it really did come from one of our resident physicians from a trainee while we were rounding on newborn babies on our labor and delivery floor. And this resident just brought up to us, it seems to me like we're doing more testing for newborns of Black moms than newborns of other moms. Is this real? Or is this something I'm just making up? And so one of the wonderful things that we've been able to do in this work is to bring out the voices of people who are maybe the least experienced in the room, but have an outsider's view. And I think that is so important as we question some of the practices that are things that we've always done in hospital settings. And so my focus here is going to be mostly about practice setting, but I do want to give you just a little bit of background for different folks here about the background of state and national policy that inform this work, and then I'll get to the study itself. I was new to the state of Michigan in 2020 when we started this work, and so was my trainee. And so much of this is variable based on our state laws and our local practice variations. And so for each of this was a little bit different than the practices that we'd had where we came from in other states, the resident from Kansas and myself from the Chicagoland area. So as we all know, the U.S. Child Abuse and Prevention Treatment Act kind of designates that states must have policies and procedures to address the needs of babies, infants who are born with and affected by substance abuse or withdrawal symptoms that result from prenatal drug exposure. So there's a lot in that statement that help us understand, the specific population that this focuses on, and really, again, from the context of opioid exposure and pregnancy, and we must notify CPS of such conditions of such infants, and then in our 2016 update requiring this plan of safe care. But while it does require de-identified notification, it doesn't require drug testing of all newborns or birthing people, and doesn't require reporting of every substance exposed newborn to CPS. In one of the other studies that we did, one of our nurses said that would be every patient in our hospital. So thinking about what the prevalence is of different substances that are used in our communities, it doesn't require a plan of safe care for every newborn that is substance exposed, right? So we're thinking just about substance abuse and withdrawal, but it does consider cannabis a substance or drug. And so what you'll hear more in our work and the work in capturing patient voices here is, what does that feel like and how does that resonate with our patients? So then to focus in on Michigan, mandated reporters then in the state of Michigan are required to report, different than notify, suspected child abuse or neglect, so that, again, our CPS team can go out and evaluate the safety of this family home situation if we know or suspect that a newborn infant has any amount of a controlled substance, metabolite, or alcohol in their body. Certainly not required when due to medical treatment, but you might suspect that someone has cannabis in their body if their mom tells you that they're using cannabis, right? So it's a little bit of this recurrent trap of testing someone for something you know is already true. And so this led to the research question, is there any difference in newborn testing by race or ethnicity at our hospital? And then we had an interesting question when cannabis was legalized in our state to see if there was any difference. The work that I want to talk to you about today is part of a multi-phase trial. And so as I put on my researcher hat, we had really conceptualized this and gotten grant funding for a explanatory sequential research design in which we were going to connect quantitative data from our EHR review to qualitative data, combining both semi-structured interviews of hospital staff, doctors, nurses, social workers, and our CPS team in the community, triangulating that with qualitative work, capturing the voices of our patients, and then in the milieu of a participatory council and engaging some experts in the community. And so we really imagined this originally side by side, but in the real world, nothing happens exactly as you plan it. So I'll tell you a little bit more about how it actually panned out. The first work that we were able to do was really just looking at the quantitative information. And so we had this data prior to embarking on our qualitative study. And we looked at data from 2014 to 2020 and were able to demonstrate that we were, in fact, doing more drug tests. And this, you all could tell me about 10 other studies in different hospital systems. And then I think we're really working on kind of the systematic review level of what we know now from all of our different sites on urinary and newborn drug testing, demonstrating these inequities, this disparity in treatment or testing between different racial groups. And so just to show you in a little bit more granularity, the top line that is circled is our patients who the birthing person, the mother, identified as Black or African American from that person's own designation of what they wanted their race to be designated in the electronic health record, compared to multiracial, which is the only bar really there that meets. And then you can see at the very bottom, the orange bar is Asian, and then white is the light gray bar kind of in the middle. And then you can see cannabis was legalized here in 2018, although that bar is not shifted correctly in my slide. And then we were able to demonstrate that there was no reduction in that testing after cannabis was legalized. And then the other thing that came out of this work is, understanding what were the results of the tests that were sent. And so identifying that for tests that were positive for opioids, there was a higher prevalence of that test positivity in our patients who self-identified as white. And for cannabis or THC, a higher prevalence for our test that patients that self-identified as Black. So this kind of gave us some hypotheses about things that we wanted to test out and getting more information in our qualitative strands. And so looking after cannabis legalization, we saw, as you like very much might imagine, just more patients tested positive for THC after it was legalized in the state. And again, when we think about a driver diagram of things to improve, like the highest percentage of tests are tests that are positive for THC only versus looking at tests that are positive for opioids and more than one substance. So this is again not this particular study, but preliminary work. The next strand that we were able to focus on was our CPS professionals and healthcare professionals. And similarly, we just did semi-structured interviews and identified that there were some findings from our hospital staff themselves into what might be driving these racial disparities. So really just gathering information so that then we can then think about some quality improvement in our hospital. From one of our nurse midwives, we call it risk-based testing, but it really does automatically assume that a woman of color is more at risk than others. This could be implicit bias. From one of our nurses, a little bit concerned that we don't have a streamlined set of criteria, right? Maybe it's because we don't have a streamlined policy. And from one of our physicians, what is really the benefit of CPS reporting and how do we make sure that we're utilizing this resource appropriately and effectively? And so again, thinking back to this convergent study design and how we focused our work on our patients in the community, we conceived of this work using 4 different theoretical and process framework foci. So one of those is looking at the focus of anti-racism praxis. And so we operationalized racism in the levels of racism framework, thinking about how this might be showing up as internalized racism and institutional racism in our hospital system. We thought about public health critical race praxis as in informing our assumptions about race and racism and race consciousness. Again, the idea of race as a social construct. We thought about centering in the margins and shifting our focus to those minoritized groups to understand their experience. And then again, the idea of praxis, treating racism as a practice of learning over time. We applied some principles of action research or participatory action research by engaging with community advocates and hospital leaders throughout the research process with the intent of really identifying ways to improve in our local setting. So these are just some of the ways that we focused the study design itself from the beginning with kind of an anti-racism lens. And so in this explanatory model that we developed for both the patient and the provider, for lack of a better word, interviews, we published this like grid or graphic with that study about healthcare professionals, just to explain to people who don't work in our setting how this might be operationalized, both in the decision to order a test and how racism might play into that decision, how it might play into the different ways that patients are exposed to poverty and other lack of access, and how that might affect what our social workers are finding, how it might play into prevalence of substance use in different communities, and then what happens at the level of CPS and how those investigations might look different in different communities. And then on the right-hand side, all of those different healthcare professional attitudes, knowledge, and experience about what they even understand about CPS, communication, and what they see the value versus harm might be to our patients. And so we had originally designed this convergent mixed methods design, and in the real world, it just didn't happen that way. So then the last strand that we accomplished here was looking at the qualitative strand for our patients. Okay, I'm going to go through like what you can just read on your own and annotate it a little bit, and then we can just talk through some discussion about the article itself. Sorry. The combination of an almond and a protein shake. Um, Looking at our team again, I'll tell you a little bit more about the different individuals that were involved in this work in a second. But our study aims were to understand and elicit recommendations from parents in our community about policy changes that we could include at our hospital to potentially eliminate these racial disparities in drug testing, which we'll abbreviate NDT here, and reporting to CPS, and to understand their experiences. What are your experiences for folks who've recently given birth regarding newborn drug testing in the first place? And what is the impact of racism and other biases on these disparities that we had previously identified? This was done in 2022 to 2023. It always feels like it takes forever to get to the end and publish your work, but we did pretty well now in retrospect. I'm publishing this work in 2025. And you need to appreciate that at this time, our hospital did not have a policy, and Dr. Townsel can annotate more like our role together in creating that policy and using these results to do that. But our like prenatal care guidelines at the hospital recommended that clinicians take a substance use history at the first prenatal visit, but we didn't mandate universal urine testing. We didn't mandate selective urine testing. Clinicians were supposed to use that if they felt it would help the care of the patient, but they did not use that to guide care of the newborn after that newborn was delivered at the hospital. And so clinicians, again, on the newborn side, coming in to meet that family at the first visit, had their own way of understanding what was the risk and how did they interpret this, what I think is not a really well-written state law about what is their responsibility to report to CPS and how are they using drug testing to operationalize that evidence for reporting. This came up in the peer review for the article. I guess I was unaware that the American Academy of Pediatrics recommends urine toxicology, just because none of our nurses want to put a bag on a baby and collect urine. But we use a meconium test. I know some of you are probably using cord tests. I know there is some controversy about which has a higher false positive or negative rate or accuracy. But the context that's important here is whatever we're finding out, those results result after the family has gone home. If there was really something you were worried about, this data is not guiding your decision for treatment of neonatal withdrawal syndrome and helping that family. So that's some of the basic context. And then our study team and who was involved, we represent different racial and ethnic identities. We represent disciplines of OBGYN, public health, sociology, addiction medicine, and family medicine. And we were so lucky to have some folks who are younger, undergraduate age, more like the age of our patients, through faculty and different lived experiences in our own birthing experience, as well as family and personal experiences with addiction. We added to this team, we basically hired or consulted with two individuals who are experts in sociology and anti-racist research and public health, and they helped us think about the framework that guided the development of our semi-structured guide and our analytic process. We also employed a National Institutes of Health certificate of confidentiality. We were pretty worried that conducting these interviews by phone or Zoom, we would potentially expose some risks for individuals that make them not want to talk to us. And so that certificate of confidentiality protect and added privacy to the information that they were disclosing to us. Throughout this process, we worked with a trusted parent advisor program that is focused in one of our communities in Ypsilanti. And we really, again, started with what questions do you think we should be asking our families? What is your experience? And then we reported back to them with the results. And I've just included a couple of snippets here. As Tasha said, I've also heard from moms that they don't feel comfortable with white doctors. Alicia said, I'm sad hearing what happened. I'm not surprised. And so again, that goes to our eligibility, our engagement of patients, and eligibility was really just patients 18 years and older who were English speaking and had given birth in the last 12 months. But we did exclude people who were actively involved in CPS cases. I think, again, the idea of just generating stress and trauma versus the learning for the hospital system, that didn't feel like it served our patient population the best. And then our purpose of sampling to prioritize participants who had different racial and ethnic identities and those who had had drug testing over those who had not. And then we did a variety of different recruitment methods through the medical record, through the community with flyers, and through the trusted parent advisors. We started paying people $40 and then increased that to $80. This was really a difficult study to recruit for. I think it is just, it's tough when you're not recruiting from a specific clinic site that is doing drug treatment and just from the community to identify people to talk to us about this. And we did all the interviews with Zoom. People did not have to turn their camera on. So it was essentially a recorded phone call. In terms of our thematic analysis, we did a reflective thematic analysis. We applied a conceptual framework and then also allowed the presence of new codes and themes to come up. And we identified really no new data after 11 interviews, but completed an additional 4 interviews. And again, we used our participatory council to understand the meanings in which resonated with them. So in the last few minutes, I'm just going to go through results and then open it up to ask questions and get your insights in how this does or doesn't converge with the, what you're seeing in your community, but just to like copy and paste the table 1 smaller study. We had a focused recruitment of patients who identified as Black or African American. We had one person who identified as American Indian or Alaska Native, and others, as you can see here. Self-reported gender identity, we had one participant who reported as transgender male, and then the vast majority of patients that had newborn testing done. And of those test results, the majority were cannabis only that were positive. So the themes that we aggregated, I think, focusing globally just on how testing of newborns affects the relationship with our patients and how they feel about CPS reporting. Our participants felt conflicted about being honest with us about substance use. And again, this is a finding that you'll see in lots and lots of other research amongst different substance diagnoses and use patterns in the literature. As one of our participants said, I got really upset. I said, I don't want to talk to you anymore. I don't want to answer any of your questions. It's like you're basically treating me like I'm a criminal. We're going to call CPS on you. And then another participant said, I just felt like I couldn't tell the doctor because they could tell the social worker or call CPS. It's like you can't really open up. This is my favorite quote. Secrets keep you sick, right? What is the experience of our patients for keeping this information, wanting to disclose, but you can't, after all, because you get punished for being honest. So really the sense of CPS reporting as punishment, and I think, if it were that the participants experienced family support, if CPS wasn't called CPS and they provided family support, we might have gotten different answers. But I think this balance of, again, like making sure your family is safe versus providing you actionable support for substance use is not what our patients appreciated. And then I pulled in one quote here from our other study of healthcare professionals. Instead of putting them into our system where we don't know what could potentially happen, we could go the other route and bring them in these preventive services. So it was really wonderful to see the crosstalk across the 3 strands of this work. The second theme was about historical and contemporary racism. And I will just say, when we asked community dwelling participants, patients, people, tell me about racism and how that affected newborn drug testing in your care. My sense is that not everyone has an answer to that question, but that people are able to very, very clearly and thoughtfully describe their experience in ways that then you can crosswalk into different levels of racism. And so it talked about how racism has been shaped by stereotypes regarding drug use. As one person said, it's because of the stigma. I feel like it goes back to the 80s when the crack epidemic started. That's an indicator that doctors just have in their mind more of an association with drug use for African American families. And then participant 3 on the right, like she went on to say that she felt like people of color have always been on the negative end of certain biases. What was interesting about this participant is that she had chronic pain and was using an opioid for chronic pain and not being treated for substance use disorder. And she just described over and over again being placed in a box, right? So in medicine, we follow checklists, just feeling like no one was listening to her, and she got placed in the box of substance use during pregnancy, which certainly didn't serve her and made her feel not well cared for. And again, this feeling that she had pain during her pregnancy that was not well controlled. She sought out a Black physician during her pregnancy and switched physicians, and just described to us the relief at having someone listen to her and treat her pain when she felt listened to and understood. What she described there again is very well described, this feeling of racial differences in handling pain. And again, she um, just had a really nuanced experience being able to explain how racism was showing up in her experience. And then this final quote, doctors might think that African American women are lower income. They don't care about their children. They're going to smoke, do drugs, having a stereotype placed on us. And then the second piece I think is really telling. We don't feel like their children are safe, so we're going to make sure there's that extra precaution. Drugs are not just in our community, they're everywhere. But what this person was appreciating was using newborn drug testing as a way to police communities, right? To bring CPS into communities where they felt like people might be irresponsible, or to judge parenting or substance use in different ways in some communities than others. And so again, like in asking the questions and creating a safe space for people to explain their experiences, we did find that there was a great appreciation for different ways that different levels of racism, and especially structural racism, were showing up in the experience of our patients, our participants. The third thing to talk about, and again, you've heard me talk a little bit about how the health system has responded to cannabis use, because we do know from our first quantitative study that a lot of the disparity is being driven by cannabis, not by opioid use. So if only I could eliminate um, drug testing for cannabis, if only I could get the Mayo Clinic to suppress the cannabis results for people who didn't have a use disorder, no one would know, and there would be no indication for CPS reporting. So many of these kind of improvement ideas that have been so challenging to implement, we were able to understand and appreciate what the experience was like for our participants. So participant 9 here, I think one useful thing to tell people is just let them know the process. When your baby's born and they do a drug test, just address the potential risk. Maybe if those had been identified earlier, I would have quit. So there's a theme here specific to cannabis, because I think our participants who had opioid use felt that they were informed or knowledgeable of both the medical risks to themselves, the risks during pregnancy, the risks to breastfeeding. But really, I think that the focus in our health system at least has been punitive, right? Like, we're going to test your baby and send you to CPS, not my obstetrician explained to me at my first visit how I can have a safe pregnancy, and was really focused on me as a person and not just kind of like checklisting this is the harm. And another participant, participant 5, you're going to tell me that it's illegal and you're not supposed to do that. Who gave you permission? This is what the newborn clinician said to her. And I said, my OBGYN told me it was okay. She's been my OBGYN for 4 children, and for each kid, she knows me, my conditions, and what I went through. She gave me the okay to do so. And the pediatrician says, well, I don't know why she said that. Who's your OBGYN? You're not supposed to do that. So I'm going to let you know right now, we're going to collect the baby's poop. And if it tests positive for marijuana, we're going to call CPS, and they're going to come and talk to you, because that's not okay. Now, if I asked the newborn clinician, they would have said that conversation went slightly differently. But we really did identify here that we have a lack of training and scripting for our obstetricians, nurse midwives, and family doctors who are meeting these folks early in their pregnancy, and this discrepancy between when we silo care into newborn care and obstetrical care. We miss this dyad, right? And, if only the obstetricians knew what the newborn clinicians wanted them to say, then we might have better experiences for our patients. And that's what's been fun for me as a family doctor moving throughout this, is seeing both sides of it. And the last theme that our participants really just wanted us to be honest with them, like, They didn't express that they were angry about us about CPS reporting and state law. They just want to know what the deal is and have us be clear and honest with them. So participant one says, that's why I wanted to participate in your study. I really hope this can make a change. They're not stigmatized. They're not fearful their baby will be taken away. They're working alongside the providers together as a team. Some people had really positive experiences. Participant 14, everyone was really supportive. I didn't feel any judgment. I felt honest, protected. I felt okay. I could tell them they weren't going to judge me. They weren't going to take my children away. And other people felt like the information that could be given really would help them make different choices. And they felt more guarded about the risk of CPS. Even if I wanted to, I'm not going to take it. I know the risk involved. They should let you know from your first trimester. That is their priority. And I think the meaningful piece of this is they should let you know as the mother, this piece of respecting mothers and equipping mothers to be in charge of their own family decisions and not this idea of policing families. So those are the four themes that came out. I have like lots of other slides that talk about how we identified racism as showing up, how specifically cannabis, we had some insights and how we've placed institutional changes and policy changes, but I'm going to stop talking at this point and see what questions there are, and we can always come to these other slides later.
Thank you so much, Lauren. That was excellent. Such a great study. And applause for, your framework and all the stages of research. I know that that takes a lot of work and dedication to a long-term project like that. So that's excellent. I love it. So I'm going to open it up to any questions, clarifications that people have. Feel free to put them in the chat, and I'm happy to do that, or people can also unmute. I just ask that you raise your hand with the Zoom function, and then I'll call on you. There's been a couple comments in the chat so far. One from Jan about a patient he had, kind of the patient that you mentioned who has chronic pain. I think all of us who do this work find ourselves in this spot, right, where other provider teams maybe don't know exactly how to take care of these patients, and they say, oh, I know that doctor down the hall does Suboxone, and we're focused on the addiction, so they end up in these addiction clinics, and it's sometimes really hard for us as providers, but like, gosh, for the patients too, to feel like they're being punished. So I appreciate Jan's comment where, kind of just a little bit camaraderie that a lot of us kind of find ourselves with those patients and figuring out unique ways to support them in this process.
Yeah, I think, Caitlin, good to see you, Dr. Weiderman. Some of you I know from the last ASAM meeting. It's really nice to kind of put faces with names now. As we're thinking about how we're going to implement plans of safe care, no matter how much we try, there's going to be a poor pediatrician at the end of this process who is not going to have as much experience with managing and understanding and interpreting, at least in Michigan, our state law, and what's required or not. And I think there's a lot of opportunities for how to communicate that, but I love like putting it in the patient's own hands to kind of deliver and making them at the center of their care.
100%. Barbara, I see your hand raised.
So as one of those poor pediatricians, I believe I heard you say, and I apologize, I'm in clinic, so I might have missed some potential nuance, which is so important in all of this conversation. But with regards to sort of like the AAP, the 2020 sort of review of NOWs and the stance on testing, it did lead me to sort of reopen it, and sort of the text that I read is, sort of the testing is indicated if it will inform clinical management. And so I think it's interesting because I think I have read that as opening space to say the testing, needs to be done with consent and needs to inform clinical management. And that in my mind, sort of it has open space to sort of say testing is not required, and that it should be sort of carefully, it is a decision to be made and should not, sort of be a default I felt like that might be slightly different than the the impression that I think I heard. But again, I'm, sort of bouncing around. So I apologize if I'm just opening up for discussion to continue to go across silos.
Yeah, Barbara, I think your comment is right on. And I think what has been fascinating about this process, and I'll just like add some detail, we have a multidisciplinary quality improvement team in our hospital, and our newborn pediatrics division lead and I have really been thinking about how can we still help our poor pediatricians feel like they're not breaking the state law. I mean, doctors are rule followers, right? For me to say conscientiously object, don't order any tests is like a stretch for some. And so we really want to make sure that as we develop a hospital policy, it stays true to the intent of state law. So it's true that in the state of Michigan, a drug test is not required for reporting to CPS. And some pediatricians feel like testing is helpful to guide breastfeeding if you're using cannabis. Testing is helpful to ensure that that person who's using cannabis isn't using or exposing their newborn to other substances. And so I think part of the educational piece is to help teams just like work through what are your biggest concerns and how can we make sure these patients get the best care and our patients get the best care. And so I really am 100% bought in on giving great breastfeeding support to people who choose to use cannabis. And I think just focusing in on, okay, what is the end game or outcome for this patient, and is that drug test necessary? I think, to be honest with you, where I hope that we go with our hospital is to identify people with cannabis use disorder. So anyone who's doing work on identifying cannabis use disorder in pregnant patients, that will help me focus a little bit more on who I might select to do drug testing for, again, to stick with the letter of the law. And the suspicion of substance use, and making sure our patients are safe and working alongside our pediatricians, again, just taking these incremental steps to reducing testing that our teams can get behind and showing them success with incremental changes and then seeing what their appetite is for other changes.
Thank you. So if you have any questions, please raise your hand or put them in the chat. I have a researchy question, Lauren. That's my job. So I know you initially said that you had this framework, right, of your quantitative and your qualitative, data, and you're going to converge it all together, but that's super hard. I can empathize with that. But then you switched to like a sequential design. And so I was just curious to hear more. In your interviews that you did you share with your participants some of your quantitative findings from your prior study and get their feedback? Is that what you did? Or did you use your quantitative findings more to drive the interviews? I'm just curious how you brought those two sets of data together, because I feel like that's really hard to do, challenging in real life.
I think that the most discreet way that we did that was to ask the question both of all of the healthcare professionals and the patients. We saw in our data that doctors are testing newborns of Black families twice as much as other families. Why do you think that might be happening? Really just to like invite team participation and exploring our data and making sure we're asking the right questions. I think what's been valuable about bringing, again, data plus stories back to our hospital is that those individual stories of how patients felt and what they wanted out of their care really are meaningful when you're trying to drive change. And so whenever I'm in a meeting, to be able to say, like, the data is, this is a disparity and it's not based in higher risk, it's based in bias. And then this is the story of the patient and how it affected them.
I love that. I feel like it's a great opportunity that we lose out sometimes, or as scientists, we're generating all of this data, but actually bringing that back to the communities where we got that data from and actually getting their context, I think is so important. But operationalizing that can be challenging with how funding works, for example. So I love that that's how you did your interviews. There's a question about developing or writing guidelines or protocols for toxicology testing. And I love what you said, Lauren, about how you're using your data to drive change. I can speak to this person too, you know, I feel like I'm in these meetings with our finally, after years of being here at my institution, we're finally starting to make some progress, for example, trying to change some testing policies, which is excellent. And I find that I keep on saying over and over again in these meetings, I think I'm going to say something that probably resonates. We should only be doing testing if it's going to guide clinical decision making. But what I've noticed in my meetings is that when I say that, like that sounds good, right? And everyone agrees with it. But when you get into the nitty gritty, because things have been done a certain way for so long, I find that people think they were ordering tests to guide clinical decision making, but they actually weren't. But that's what people think they've been doing because it's just like, well, that's just the way we do it. And therefore, of course, it's medically indicated. And I've noticed that I find a barrier to even explaining what medical, you know, what the definition of a test only for medical decision making looks like. And it's anti what people have in their brains, not their own fault, but just the way that the system has worked. So I'm just curious to hear in your hospital leadership meetings a little bit more about how, and going off this question of how you take your data and use that to drive some changes, kind of knowing kind of the biases and perspectives that are very historically rooted in a lot of these isms that you talked about that can make it extra challenging.
Yeah, I think with Dr. Courtney Townsel, who was here and had to leave, is now at the University of Maryland, and she's a maternal fetal medicine specialist who at the time was had a focused practice in substance use disorder treatment and pregnancy at our hospital. And so as we essentially made a hospital policy protocol for testing, we really just used expert guidance, right? So taking what we know about uh, uh, indicators of substance use when you're in a hospital system that doesn't use universal testing and knowing that universal urine testing is just a snapshot in time and would not give you a true prevalence of substance use in pregnancy. And we did that and implemented that policy on Valentine's Day of 2023. So I'm just now looking at the data in the first year of analysis. No, maybe we did that in 2024 through 2025. That would make more sense. And so we had on that initial list, looking back at the questions, late to prenatal care. And we just made a guess. 20 weeks, right? If you haven't come in for an anatomy scan at 20 weeks, like that is our definition of maybe missing some integral pieces of prenatal care. Feeling like in our setting, some of our obstetrical practices cannot get people in the first trimester, and I don't want to punish patients for that. So a piece of how to operationalize unbiased guidelines, I think, is to really think a little bit more critically about like which time point or which definition might lead to more bias than something else. So then after a year, we went back and looked at our data, and I'll share screen again to just show you a couple more of the really amazing things that our pediatrics focus team did. So we kind of developed and implemented a new policy. We implemented a monthly dashboard, which again, I wish I used more than a couple of times a year, but I do use it a couple of times a year with our QI team to say what changes do we want to make. And you can appreciate that this brown line being the higher rates of testing for Black newborns. Spoiler alert, we haven't made a significant decrement or decrease. And then, ooh, do I have that in here? No, I don't. I don't have it in here. That we put into place an order set that has like the reason you wanted the test. And you have to make a selection, and it's like a hard stop. So that data then comes back to me, and I can tell why did the person order the test. So that allows us to do some retrospective chart review. At any rate, a lot of the folks where the only indication was late to prenatal care were definitely using substances that were concerning and showing up for their delivery. So while I'm not comfortable removing that as an indicator for assessment and testing potentially to guide treatment, we might refine it, right? We might refine like no prenatal care before 36 weeks or whatever it is. So that data, I think, is going to allow us to get a little more granular. In our community, choosing 20 weeks as the cutoff, that wasn't a driver of the racial differences in testing.
Oh, thank you so much. That's really great to hear some of the practical applications of what you did, and then also hearing about how you're able to look at your data to see what actually was driving the disparity, and use that to guide your decision of maybe not necessarily what you're going to do, what not to do, but what to prioritize, right? Because sometimes we can't get everything we want, but we have to pick our battles. Any other questions that people have? Okay, I don't see anyone. Okay, great. Well, Lauren, thank you so much again for coming to present to our group. We really appreciate you. And thank you everyone for sticking it out to the end. Just a reminder that this recording will be sent out in the WAG listserv, and then we also will be sending out the invite for the next journal club. Please mark your calendars for Tuesday, September 23rd at 10 a.m. Eastern Standard Time, which will be going over breastfeeding guidelines, which actually works out pretty well to be after this journal club, just given all the conversations we had. So thank you guys again for coming, and we will see you at the next journal club. Have a great day.